On history, gout will usually present with sudden onset pain in a particular joint. It most commonly affects a single joint, usually the first metatarsophalangeal joint. However, it can affect any joint in the body and also multiple joints at the same time. Because the first metatarsophalangeal joint is the most common area, it has a special name, and that's referred to as a podagra. On history, the person may also present with some risk factors. So maybe they have obesity, maybe they follow a diet that is high in purines, so that would include things like shellfish, alcohol, sugary drinks, and that's because purines in the body are converted by the liver into uric acid, which is the cause of gout. The person may also have a few comorbidities, so kidney disease, hypertension, diabetes are really common associations. And also, depending on how the patient is, if they're in a high catabolic state, so if they currently have sepsis, then that puts them at risk of gout as well. On examination, you may note a red, hot, swollen, tender, and often shiny joint. In some cases, you may also note some tophi, which are essentially what look like little rocks under the skin over the extensor surface of the joint. In terms of investigations, the gold standard is an arthrocentesis, which is essentially putting a needle in the joint, aspirating a bit of synovial fluid, and then sending it off for synovial fluid analysis. When it's analysed, the person may note some monosodium urate crystals, which appear as sort of needle-shaped crystals that have this feature called negative bifringence. And that just is a term to refer to how it refracts light under the microscope. Once a definitive diagnosis is made, further aspirations aren't usually required unless you suspect it's an infection. So septic arthritis is one of the main things that you want to differentiate gout from. A serum uric acid level is also a really important investigation. With that said, it's not usually involved in the diagnosis of gout, as a patient may actually have an acute gout flare with a normal uric acid level. Renal function is also important, as it is both a risk factor for gout and also a consequence of gout, particularly if it's uncontrolled over a long period of time. And that's because gout crystals can deposit in the kidneys commonly. An X-ray is commonly done, and it may be used to see joint damage from gout. However, you won't see the crystals themselves as they're not radio-opaque. In terms of management of gout, we can split this into management of the acute episode and the more long-term chronic management. So in terms of management of the acute episode, it all centers around anti-inflammatories. So you have a few options here. The patient can be prescribed NSAIDs, so non-steroidal anti-inflammatory drugs. The most commonly used is indomethacin traditionally, and this is because it's short-acting and can have the dose easily titrated. In terms of other options, you have systemic corticosteroids, local corticosteroids. You just want to rule out infection if you do use it. Colchicine is also used at a low dose. Just have to consider the side effects, which can be things like nausea and diarrhea. Usually with optimal management, symptoms usually subside in days or 1 to 2 weeks. Next is the more long-term management, and this consists of making sure a person's uric acid levels are within a certain range. This is really important, as not only can recurrent flares of gout lead to recurrent flares which are really just inconvenient and painful, but it can also lead to these chronic changes at a joint because of the constant chronic destruction of the joint. So you get some arthritis there. Urate crystals can also deposit in soft tissue and kidneys, so it can lead to impaired renal function in the long term. In terms of what we can actually do to manage it lifelong, there's non-pharmacological strategies and there's pharmacological strategies. So the non-pharmacological strategies would consist of making sure the patient is maintaining a healthy lifestyle, limiting their intake of alcohol, limiting fructose-sweetened drinks, and also the purine-rich foods that we mentioned earlier. Thiazides and loop diuretics, we should think about whether we can change some of the diuretic choices or if we can use a different dose. But it's a tricky one to get right in that case, as they're usually on the diuretics for a good reason. In terms of pharmacological strategies to lower someone's uric acid level, this will include things like allopurinol, which is first line, and this works by inhibiting xanthine oxidase, which is an enzyme used in the body to form uric acid. If allopurinol is not tolerated or it's contraindicated, then you can try things like febuxostat or probenecid. The dose of your allopurinol should be titrated based on your uric acid level, and different guidelines will probably have different thresholds, but just keep in mind that tophaceous gout, so gout with the presence of tophi, will have a different target concentration to non-tophaceous gout. An important concept to keep in mind is the relationship between someone's uric acid level and their risk of getting a gout flare. The thing is that anything that suddenly increases or suddenly decreases their uric acid level will make someone at a much higher risk of getting an acute gout flare. And that applies to the time of commencing someone on allopurinol, as it's a urate lowering therapy. So it may actually decrease their level quite quickly, which makes them at a higher risk of getting a gout flare when you're titrating the dose. Because of that, when you're starting someone on a medication like allopurinol, you want to make sure that you have flare prophylaxis as well at the same time. So that would mean practically commencing allopurinol and colchicine at the same time to lower their uric acid level, whilst also reducing their risk of having an acute gout flare whilst you're titrating the dose and sort of mucking around with their uric acid level a bit. Now, by that same principle, if someone is already on allopurinol and then they have an acute gout flare anyway, then you don't want to muck around too much with their allopurinol dosage or stop it, because by that same principle, if you change their urate lowering therapy, that's going to change their uric acid level quite quickly. So that can end up prolonging the acute gout flare. So you usually want to leave it and then just give them the flare management that we talked about. So the colchicine, the NSAIDs, or the corticosteroids. In terms of how regularly to check someone's uric acid level whilst you're titrating allopurinol, usually monthly is recommended, at least by Australian guidelines. And then once you reach their target concentration of uric acid, checking annually is usually okay, but that may change depending on how many flares a patient gets. Anyway, that's gout, at least my understanding of it.